Well, welcome everyone. I'm John Miller. I'm Executive Director of the Mid-Atlantic Business Group on Health. We are an employers coalition here in the Washington, Baltimore area, and we are partners with the Mental Health Association of Maryland on the Mid-Atlantic Path Forward for Mental Health, which you will hear a little bit more about from Michael in a few minutes. I'm really privileged actually to welcome you all here today. Employers are very grateful for the people on the call today. Those of you who are doing the work of implementing collaborative care, you're making life better for my members, employees, and dependents and retirees. Thank you. Maryland Medicaid for reimbursing for collaborative care. You're making it financially viable. We're grateful for that. Thank you. And soon to hear from Blue Cross Blue Shield of Maryland for your excellent support for collaborative care. It's unprecedented across the country to my knowledge, and I assure you, employers are noticing Blue Cross Blue Shield of Maryland and Bill Beecroft. Thank you very much. So before I turn it over, I'll just say once again from the employer community, thank you all very much. We're grateful for you folks putting collaborative care into place. It's making life much better for our employees, our dependents, and our retirees, and the whole community. So thanks a million. And with having said that, Michael, I'm going to turn it back over to you.
Great, thank you very much, John. So I'm Michael Uhas, and I see some of the folks who have registered today have been on one or both of our previous lunchtime webinar series in collaborative care. So I apologize in advance for redundancy that some of you will have already heard. But we originally scheduled 3 of these sessions, and we're actually evaluating whether we should add additional webinars to this series. It was intended to be a brief series, but we've gotten very good feedback, very good receptivity to it. So Sam, if you're there, if I could get my first opening slide up. Okay, so again, some of you have heard some of this already, but we put this series together in part triggered by the new Maryland legislation, which you're going to hear a bit about from Claire Gregory momentarily. And as we began putting it together, the idea was to put together real life situations where collaborative care has been implemented in different settings, different provider systems, and provide the opportunity for folks in the Mid-Atlantic to hear how it's being done elsewhere, as well as in Maryland. We have had several Maryland presentations as well. The presentations are 15 to 20 minutes each, followed by a Q&A. And the focus is really on kind of how the programs came to be. We'll have a little bit of an exception with Claire's presentation because the timeliness of the new Maryland law authorizing reimbursement for collaborative care under Medicaid, that's about to hit. And we saw it as a golden opportunity while Claire and her team at the state are putting together the final touches as we roll this out to get an update on where everything is there. But short of that, it's really designed to talk about programs that have been implemented. And as always, we like to thank some of the sponsors who helped to get us to this point. You'll see at the bottom of the first slide, OSI of Baltimore, the Leonard and Helen R. Stolman Foundation, and Johnson & Johnson are 3 organizations who've been very helpful to the Mid-Atlantic Path Forward. And, we thank them again for that. Next slide, Sam. Okay, so the Path Forward, just a word about the Path Forward nationally, is an initiative that is supported by some very, very capable and wonderful to have on board organizations, as you see across the bottom of the screen. And I'm an advisor to the Path Forward nationally, as well as in the Mid-Atlantic. And the focus of the Path Forward broadly, as well as in the Mid-Atlantic, is on keying in on a few specific reforms that are scalable, can be put in place. There's already evidence there. And we are doing everything we can collectively, nationally, and in the Mid-Atlantic to further the advance of collaborative care implementation. And now with the new law in Maryland, we're hopeful that that will actually spearhead additional implementation interest now that Medicaid will be covering it. Next slide. Okay, the regional implementation partners for the Path Forward nationally, if you look on the right side, Mid-Atlantic Path Forward, there are 8 of these sort of operating implementation partners that all take the work of the national Path Forward and try to put it into action regionally. So what we have done in the Mid-Atlantic is focus heavily on collaborative care, which is again what's behind this particular series. Next slide. Okay, the collaborative care model itself, just to clarify, we recognize and appreciate there are multiple models for integrating behavioral health into primary care. And we're talking about a specific model here, the collaborative care model, which many of you will recognize from the AIMS Center at the University of Washington, where the PCP maintains responsibility for all treatment of the patient. And the evidence-based care that's delivered is a combination of the behavioral health care manager, the medical provider, psychiatric consultant. So this is the model we're talking about today. And again, it's not in any way to not acknowledge other models. Next slide. Okay, so today we've got 2 presenters, and we're delighted to have both of them. I'm not sure if Bill has joined us. If not, we're going to ask Claire to go first. But by way of introduction, Bill is the medical director for behavioral health at the Blue Cross Blue Shield of Michigan. Many of us within the Path Forward who are working with the Path Forward have had the pleasure of watching Bill's efforts unfold over the past few years in Michigan. And we think, you're going to be delighted. We've heard some of what he's done already, but his more recent work with child and adolescent collaborative care is of incredible importance right now. So we're looking forward to that. And then Claire Gregory is Senior Program Manager at the Office of Innovation, Research, and Development at the Medicaid office with the Maryland Health Department. So Claire also has had a very important background relative to the Medicaid pilot in Maryland that actually led up to the passage of this new legislation in the state. So we're really looking forward to hearing from Claire about where things are today. So has Bill joined us? Sam, can you tell? Okay.
Sorry, I couldn't get myself unmuted. He is not.
Okay, then let's ask Claire. If Claire, if you would just take it away with the first presentation, then we'll allow Bill some time to resolve whatever technical problems he's had. So,
sure, Michael. Yeah, I'm happy to do that for you.
Thank you.
Sam, would it make sense if I shared my screen?
That'll help.
I believe I have your slides.
Okay. Okay, all right. Take it away. I need a little bit of feedback. I can turn myself down too. So good afternoon, everybody. I really appreciate you allowing myself and Maryland Medicaid to join. Like Michael said, I'm a senior program manager, and I work within the Office of Healthcare Financing for the Office of Innovation, Research, and Development. So we kind of function similar to like a policy wing for Maryland Medicaid, and I'm really looking forward to presenting. I just want to thank everybody at the Mid-Atlantic Path Forward Group for having us. Sorry if I just put that. But I also want to acknowledge my colleagues who are on the phone with me today. We have a fairly large group dedicated to this statewide expansion of the benefit or of the pilot. I'm joined by 2 of our division chiefs, Nancy Brown, as well as Sharon Neely, and then multiple wonderful health policy analysts. We have our project coordinator, Liz Herrick, Kathleen McGuire, and Hannah Marcus as well. So we're very excited to talk to you about what Maryland Medicaid has been up to, and we're really looking forward to receiving your feedback. Really, today's presentation is going to be split into 2 areas. I want to give a little background about our work with the collaborative care to date from a pilot standpoint, and then I'm going to talk about the statewide rollout of this benefit. And not to vary the lead for the presentation, collaborative care will be effective as a covered Medicaid benefit in Maryland starting October 1st. So that's why I'm here. So I know we have a lot of subject matter experts on the phone, so I don't want to talk too much about what collaborative care is, but Michael, the slides you presented at the beginning hopefully was seen. Again, it's a patient-centered, evidence-based approach for integrating physical and behavioral health services in primary care settings in Maryland. It includes care coordination, systematic monitoring and treatment using a validated clinical rating scale, regular systematic psychiatric caseload reviews, and consultations for patients. And really it's that joint effort for medical professionals. And we really see the patient as part of the care team as well. So next slide. I think it's important to talk about the pilot first. I know we're hard at work here at MDH and we don't always have time to shout from the rooftops about what we're doing, but I want to give you an understanding of where the pilot was and then how we're having the benefit roll out. So in 2018, basically, the General Assembly passed House Bill, let my screen, so I'm not like looking to the side, sorry. Passed House Bill 1682, which established our pilot program. We were required by law to come up with a pilot for Medicaid that was in a primary care setting, specifically to administer collaborative care as an evidence-based model. So that's what got us rolling, right? It was a law, it was put in the governor's budget. It really put the onus on us here at the department to do this work. So that's key factor to highlight. The bill language itself required that there's at least 3 or an attempt for 3 pilot sites with specific characteristics. That included a rural setting if possible or feasible within the applicants. And then we were also required for findings and recommendations to the governor and the General Assembly prior to November 1st of this year. The Joint Chairman's report was submitted last month, actually. I think it was last month. Or in 2021, sorry, in 2021. And is available on our website. I have it linked as a resource in the slide deck too. But what you'll see is that second part of the slides here, the bill is requiring the governor to include $550,000 in his annual budget for 4 fiscal years. And then also, in order to waive the general Medicaid requirements of statewide-ness, we had to apply for an 1115 health choice demonstration waiver. So we submitted that to CMS in April 2020. That allowed us to just try it out on the pilot level. And restrict geographic to the awardees. And then we implemented, really service delivery started in July of 2020. So as you can imagine, we started this work pre-COVID, very excited and strong. And then we got joined the whole world in the public health emergency while we were rolling out a new benefit. But we've had great success and it's been great, but just a caveat too with our data and results. So you can go over to the next slide. Right, so this is mainly to talk about pilot delivery, like what it looked like. So based on the bill that was submitted in 2018, the department did a request for applications process in 2019, and we awarded Privia Medical Services as the award recipient, the grantee. And they had 3 areas that they highlighted in their application. They had sites in rural locations, urban locations, and OBGYN locations across the state of Maryland. And I don't know if you saw in my bio, but I'm a native of Eastern Shore, so I was trying to not be biased and excited to see the rural location. The funding from the bill allowed us to provide one-time infrastructure funding for 1 year. And that was in fiscal year 20. We made $225,000 available. That was used for connections, interoperability, different things like that. And again, trying to get this rolling while the department was just beginning to go full remote. And then services were $550,000 were allocated annually for state fiscal year 21 to state fiscal year 23. So again, that service delivery started in July of 2020. For participants to be eligible for the pilot, they had to be on Medicaid, and then they needed to have a diagnosis of mild to moderate depression or anxiety using a validated clinical rating scale. Privia invoiced us on a quarterly basis. Basically, we use secure file transfer protocols to receive data. We analyzed it, confirm Medicaid eligibility, and then they were paid on a quarterly basis. So it was a physical invoicing process, not electronic claims. And that's why I really have to give a shout out to the pilot team here on the call, because we were all a part of that. And we learned a lot. And then also, again, that bill component required an evaluation. And then since we placed it into our 1115 waiver, we're required by CMS to do health choice evaluation reporting. So There's some small information about it in our health choice evaluation that gets released annually. And then the joint chairman's report that we wrote has data and evaluation metrics as well. So those are linked at the bottom. And then I want to highlight one thing about the pilot. We really leaned heavily to resources from the Ames Center, from the University of Washington, and New York as well, to help us implement the pilot and create standards and kind of gain our subject matter expertise too, because we're policy people here, right? So we want to make sure we understand what we're helping roll out. So these are some patient outcomes for 3 quarters of fiscal year 21. We saw decreasing scores for the PHQ-9 and the GAD-7, so there were improvements in depression, anxiety. 65% of people who are enrolled for 70 days or more had clinically significant improvement, and then baseline scores dropped more than 50%, or some scores dropped below eligibility of that mild to moderate diagnosis. So dropped below eligibility levels for the pilot, which is great. Next slide, please. Right, so here's the change. Basically, Senate Bill 101 was passed in this legislative session, which effectively repealed the pilot and made collaborative care by law required to be covered by Maryland Medicaid effective October 1st. We anticipated, that this could be coming. We're trying to read the tea leaves and understand, what where the advocates were going and where the legislature was going. So, we're happy to see this, but that meant that effective tomorrow, our pilot's over, and then it's now covered. Collaborative care is now covered as a statewide benefit. So basically, we estimate that like 49,000 Medicaid participants could be eligible for the benefit, and that does include people in our health choice population who are enrolled in health choice with the MCOs and who are fee for service as well. And then kind of looking at what participation looked like in the pilot based on eligibility, we're approximating it's 58% could enroll. So, and I'm going to talk about the timeline of what's going on with the benefit and what it'll look like for everybody. So to get ready for this, again, with that effective date of October 1st, a couple policy levers and things have to be in place. One of which is the department contracts with our managed care organizations. So we work to get those updated for state fiscal year 24, which starts July of this year. So those have been updated. So MCOs are able to receive payments for this benefit. We have been working very diligently on a provider transmittal out to our managed care organizations, and that was just distributed 2 days ago. So I'm going to walk through some of that with you today. The benefit's effective on the 1st, and then we are required to submit a state plan amendment to CMS by December 2023 to make sure we grab those federal matching dollars and have this as a full benefit for participants here in the state. And we have drafted regulations, and we anticipate that they're going to be published on January 9th of this year. So again, with the kind of staggered contracts and effective dates and regulations, we're trying to make sure everything's lined up correctly for providers to be able to start billing as soon as they can, which would be Sunday. Thanks. I can do that. Let me get the next slide. Yep, thank you. So the bulk of explaining how this benefit works could be seen from the provider transmittal that went out on the 27th. Basically, we talk about, I'm going to talk about enrollee eligibility criteria, provider enrollment, reimbursement, and coordination with behavioral health services and health homes. What I want to reiterate or state really is that this benefit by law was required to be effective on the 1st, and our team has worked really hard to get to that finish line, but we are also well aware and are looking forward to accepting feedback from our stakeholders about what this looks like on the ground and how we can assist with different areas that might feel vague. So appreciate you guys letting me talk today, and happy to hear more from you. Right now, let me talk about enrollee eligibility criteria. Go on to the next slide, please. Basically, the benefit is an expansion of the pilot work that's already happened. So it's the same enrollee eligibility. It's, you have to be on full Medicaid. You need a diagnosis of mild to moderate anxiety, depression, or substance use disorder, and which is really the same criteria that was there for the pilot. And that's on the provider to determine and use as they bill us. So next slide. So the billing provider for this benefit is going to be a primary care provider, of course, working with that team of behavioral health and the psychiatric consultant and the patient. But the primary care provider would need to be enrolled with Maryland Medicaid. You can do that through ePrep. We have a lot of resources that I can shoot out to people if they're not currently billing Medicaid. And also by billing, you're attesting that you are practicing the collaborative care model in accordance with the evidence-based requirements. That is something we're continuing to make sure we understand and validate on our end at the state level, but what we're hoping is that there are already providers doing this model, and then we're giving you the option to now bill. This is a covered service through Medicare. So we're hoping we can grab those providers who are already doing it and allow them to start billing Medicaid for their participants. Next slide. And then we have I have the payments listed here. So there's three codes here, the 99492, 93, and 94. Those are the different payments per unit rate. If you're not familiar with them, I'll read the descriptions for you. The 99492 is the first 70 minutes in the first calendar month for behavioral health care manager activities. And then the first 99493 is the first 60 minutes in the subsequent month for behavioral health care manager activities. And then 494 is for additional 30 minutes in a calendar month of behavioral health care manager activities. One thing I would say about the rates, I had a note for you guys here. You can bill either one 60 or 70-minute code per month and up to 2 additional 30-minute codes per month. And we have that outlined in the transmittal as well. And then the next slide is the billing rate and billing code for federally qualified health centers. So same thing, the reimbursement is $145.08 for a minimum of 60 minutes in the first calendar month. The next slide. So coordination with behavioral health services and health homes. So I know this is the most probably interesting component of the benefit that we're here to talk about and get feedback on, but the goal here, right, is to make sure the providers are coordinating their care and they're not being duplicative of ASO services that the patient's already receiving. However, and broadly, participants shouldn't be in receipt of specialty behavioral health services because the purpose is to really manage these conditions in a primary care setting. But we recognize that we're not excluding receipt of care at the ASO. That's not an automatic exclusion for the benefit. When we were operating the pilot, it was automatic. The behavioral health care managers had to reach out to the ASO and confirm if they're receiving any services, and that was an automatic exclusion. What we're trying to do is understand that 2 things can happen at once. So we're currently working with our MCOs and the ASO to define the workflows and confirm there isn't a duplication of care, but people aren't excluded at the same time. So it's an ongoing conversation. The next slide, I think that's the end. Yeah, I just have the resources linked here and then questions. So I really appreciate you guys letting me talk to you about this benefit, and I'm open and my team is open for questions.
Great, thank you very much, Claire, and we'll open up to questions. And we also have the chat room open if you want to put questions on there. So, well, let me start, Claire. I have a question on the pilot is ending. Will there be further data analyses conducted of any type on the data that have not yet been looked at, based on the preliminary report that was published, a year and a half ago, maybe, or will there be any updated analyses, or is it just over with?
Great question. I know our division chief for data analytics might be here on the phone, Nancy.
Yep.
Thank you.
So we will probably incorporate that data into our upcoming health choice evaluations, but when the bill was passed to expand the pilot statewide, they actually removed the requirement to do a final evaluation of the pilot. So we will still need to evaluate it for CMS, but we won't have that same state level requirement.
Okay, thank you. It seems like there's some richness of data that may still be out there that would be useful to look at, but thank you. Other questions? Okay, one more from me then. On the billing of the 99494, did I understand that is limited to 2 per month? Two billings for that code, the 99494.
Yeah, you're right, Michael. I think I kind of glossed over it. We have that in the transmittal right now. It's, you can bill either one 60 or 70-minute code per month, and then up to 2 additional 30, which is the 9/4.
Okay, all right, well, thank you.
We are allowing for that limit of 2 to be exceeded based on medical necessity, but we're still working with both our MCOs and the ASO to ensure that we have the correct utilization criteria in place, that when we're doing those reviews to see if it's more services are necessary, that review is being conducted properly.
Yeah, thank you, Nancy. And I suspect there would be some interest in that, given what we've seen elsewhere. There, has been concern in places that, the limitation of two billings for that code, presents some issues for some patients, but it's great that you're looking at it. Okay, any other questions before we transition over to Dr. Beecroft? Okay, then, if you have any additional, put them in the chat room. We'll see if we can get back to you before the end of the session or even after. So with that, again, we had unfortunately, some technical difficulties getting Dr. William Beecroft on the call, but we are delighted to have him here today. As I mentioned earlier, those of us affiliated with the Path Forward have had the opportunity to see some of the efforts come to fruition in Michigan that were driven heavily by Bill and his team. So, Bill, if I can turn to you, I think we have your slides teed up and look forward to your presentation.
Sure. Ready to go. Thank you. I probably won't stay on video very long because my internet is kind of wonky today. I'm not in the office because of the UAW strike. We've not been going into the buildings themselves.
Yeah.
So that was some of the technical aspects of this as well. With that, we'll be going through a couple slides pretty quickly, and I'll focus on our additional module that we had. But you can go to the number 2 slide, move forward a little bit. I'm not going to go into collaborative care. You kind of had a good primer on this. You all know about it really well. It's really population focused, measurement guided, and evidence based. And we've been doing this since about 2017. When it first came out as a Medicare product, and then we moved into the commercial space later that year, and did a lot of actually reconfiguring of our codes to be able to make it more functional. And then based on feedback in that first year from some of our first adopters, we actually modified the restriction on the 4 code that was previously discussed here. Because what we're seeing is the initial evaluation can sometimes take up to 4, 5, and 6 hours with a very complex medical and psychiatric case. And there's no doctor in the world that's going to spend, $150 an hour on a case manager and not get paid for it for 4 of those 6 hours. So that's been something that's been very helpful. We have not seen any abusive use of that. So that's been the positive side in the whole time that we've had this program running. So that's been a real benefit. And internally, we had made this a preventive service. We would like to see the USPTSF actually make preventive service because that would help eliminate the copay where possible. There are some programs that you can't eliminate copay, but we found a 55% dropout rate the first copay drop. So that first month, patients would drop out of it. And it's really penny wise and pound foolish when you look at it as a plan, because you can slide to the next slide. For the potential of roughly $1,200 a year of savings with people that have complex medical issues and behavioral health issues, you're getting what, maybe $300 in copays. You're losing a significant amount of money when you look at it from a money standpoint, but you look at it from a quality of life standpoint, it's huge. To not have collaborative care. We've seen really significant benefits from it. Moving on to the next slide. So with that being said, what we have done is we paired up with our training partners, University of Michigan and Michigan Institute for Collaborative Clinical Systems Improvement, which worked with us on developing a curriculum modified from the AIMS program, but only slightly. We really borrowed from them heavily and worked with them, coordinated with them a lot to be able to pull our curriculum together. And we also had squirreled away money previously for practice transformation funds that we did tap into to incentivize our practices to close down for the day to get the training. We actually have 24 hours, so it was 2 days that they ended up coming. And the docs didn't have to do that much. They only had about 5 hours, especially if they'd taken, the psychiatrist had taken the training program either through the AIMS or the APA or the family practice for the primary care doctors. So with that, that really kind of got us off to a good start and able to train up 240 practices that we now are designate. The reason that we put a designation program is because the issue of fidelity of the model. There's a lot of resistance whenever you do something that's a revolutionary change to drift back to the old ways after 6 months to a year. And this is even in the context that we do a pretty thorough practice analysis for practices coming into the training and starting to work with us, that everybody's on board with this and they're committed to doing this. So with that designation, we actually go back and do audits of, are you doing the systemic case review? Are you having the psychiatrist there being able to talk with the behavioral health care manager? Is the behavioral health care manager doing care management activities, or are they doing psychotherapy, which is not part of the program? So rather than being a co-located practice, it's actually collaborative care. With that, we've trained up 800 individual practitioners, and we have about 1,200, 1,300 or so practitioners that are billing this. They didn't all have to go through our program to start billing us for these services. So we had a lot of de novo practices that started up and have really become part of our program. With that base training, we have looked at and listened to our practitioners, and many of them being pediatricians. We've got such a huge problem with kids, with the suicide rates that are just crisis potential, crisis levels. And the difficulty with the pandemic sure didn't help them any either, with significant depression and anxiety disorders. And the pediatricians were saying, hey, we can't deal with these. We need some help. We need to be able to do this. And collaborative care would be a way that we could really work with our patients and the kids of our patients that really need these kind of services, but can't get into a psychiatrist for 3 or 4 months. They can't see a therapist for a month or so, just because of availability of services. So with that, we created a add-on module that I'll go into. You can move to the next slide. Really looks at the unique issues that kids have when it comes to behavioral health issues. The benefit of the collaborative care is they at least know the primary care doctor and the team at least a little bit. They've gotten their immunizations, hopefully. They may have gone in for a cold or flu sometime in their lifetime. So when they're, an adolescent or even a late childhood child, they have a familiarity with the office setting, the people that are going to be working with them, and have more of a comfort level of being able to then work with the behavioral health care manager to do a very thorough assessment of what's going on. That assessment is much different than just the assessments you do in the traditional collaborative care for adults. You're talking to family members, you're talking to significant other support people that they have, maybe a coach, maybe a teacher. You're looking at all of the people that really touch that individual, what kinds of services they've had previously, what's worked, what hasn't worked, and being able to do that thorough psychosocial evaluation that takes time to do. It also takes a lot more effort, and we find that the behavioral health care manager can't manage more than about 60 to 70 cases at any one point in time with the pediatric focused practice. Then coordinating that with a psychiatric consultant. This could be a general psychiatrist that has had some training in pediatrics or feels comfortable being able to take care of pediatric patients, or a child psychiatrist. Generally, because of child psychiatry not being terribly available, we default a lot to general psychiatrists that have a comfort level and have taken CME courses, and also their practices having taken care of kids to the level of comfort they have. So there is It's not the best circumstance in the world for access, but it's better than what is there without collaborative care. The screening tools are all the usual adolescent child screening tools. The one that we default to a lot is the PHQ-9A, also the GAD-7 that's related to kids. But you could do the CAFIS, you could do other ones more specific to that for adolescents and children. The thing that we've noticed back in our feedback with this is that the families really like this because the families are really involved. The primary care doctor can meet with the parents, can be able to talk with them, be able to explain what's going on as best possible with the child, the interventions that are necessary, and be able to do that in a way that's being measured consistently to see if there's progress. All of the things that are key to collaborative care. You can move on to the next slide. I believe that would be helpful to see. The benefits are that the quality is really improved. The access is amazingly improved. The behavioral health care manager can be working simultaneously to get the individual into family therapy, say, or into individual therapy for the child, and maybe identify other case finding in the parents. Dad may be drinking too much, mom may be depressed. It could be the other way around, you know, whatever is going on, because they all have our insurance in general. And that way they can be able to reach and get good quality care in addition. And we look at this in a more family systems kind of model of being able to heal the whole family, not just the identified patient. Could be some of the other kids. Maybe there's an autistic child in the family that's getting so much more attention because of their needs that this child is feeling left out, depressed, and to be able to identify that whole systems issue and repair that, because then that helps this family to really move forward the rest of their lives with how to be able to handle those kinds of momentary or crises that come up. Now, if you need a specialty psychiatrist, say a person has a severe behavioral discontrol, maybe they've been really vaping cannabis and now have started to what I call unravel a psychotic disorder that they would have developed when they were older possibly, but now are psychotic. That is not really something that can be handled in an acute care, primary care setting, an acute psychotic disorder. But we have had, once they're stabilized and back to a very stable state, we can manage patients with antipsychotics and continued psychotherapy in the primary care setting. So again, it really influences the care and keeps them in care without tying up valuable psychiatric resources or psychotherapy resources for people that are stable, doing well, back to school, back to work, those kinds of things. You can move on to the next slide as well. So I think it goes without saying that we're looking at trying to improve the outcomes. We're in a big study right now with our data. We have roughly about 5,000 people that have been taken care of through the collaborative care process. I've got some numbers for the kids as well that I'll get to in a minute. But we've got enough N at this point that we can start looking at year 0 before collaborative care started, year 1, year 2. We're only into year 2 with the pediatrics, but we're into year 4 now for some of the adults. And to really be able to see if the expected total spend goes down to the kind of more approximating a person without a behavioral health condition with that same medical problem. And we're excited to be able to see those results. We're about halfway through that analysis, so we may have something in the beginning of 24 to be able to share. And I'd really like to get this at least into some, publication that we could be able to get this out to the population to show that this really does work, especially if you maintain the fidelity. You don't try to mix collaborative care and co-located care and other versions of this. We really want to see the knowledge transfer from the psychiatrist to the primary care doctors is going along well. We have that anecdotally. And myself being a consultation liaison psychiatrist, this is what I did for 38 years in my practice. Every morning when I made rounds in the hospital, I'd bump into the local primary care doctors. Hey, I've got this case this afternoon. What do I do? I've had them on Prozac for a year. They're still depressed. Well, you probably should have changed the Prozac a while back, but you can switch them to something else this afternoon, and let's do some screening tools to see that they're on track for getting better. So those kinds of things do transfer, because once a primary care doctor, these are smart individuals, they will pick up on the simple things and be able to take care of those. What we found, even with kids, they're picking up on the more complex issues, how to be able to deal with behavioral discontrol, those sorts of things, without really getting a whole lot of input from the psychiatrist and the behavioral health review system that we have in collaborative care. That actually happens, but we want to make sure that we can document that in a way that's meaningful and be able to move forward. I know I want to leave some time for questions, but I've got a couple more slides to show you. You can move on to the next slide. With this one, it kind of goes through all the benefits that we see. And I think the biggest thing is this widespread and frequent screening has really been the most valuable piece that our primary care and our pediatricians. We also have an OB-GYN module and a substance use disorder module that we've added to that. Both of those don't have as much time on them as the pediatrics and general adult co-care. But the screening has been a different issue. Primary care doctors have been doing A1Cs for diabetics for at least 15 years, 20 years, and they get people to less than 7 A1C pretty frequently by doing that, especially with some of the new medications. We see that exceedingly important in behavioral health, and we're not doing enough of it in the practices. Collaborative care really makes that a key component of this. And that, I think, is changing the way that behavioral health is being seen compared to medical services. Is it's being just another medical problem that can be treated, can be focused on, and can help people get better. We also want to treat to target, which is the big thing I want to leave you with as well. You can't just screen and then not doing something about it. And the other piece of the screening is, and this is something near and dear to me, especially in the last day or so here of Suicide Prevention Month, is that people are asking the number 9 question: are you suicidal? Have you had thoughts of suicide, etc.? In the past, it was, you haven't had thoughts of suicide, have you? And you'll get a no every time. Whereas now, if you ask it the way it's supposed to be asked, you can actually ascertain if people are in trouble. And because you've got the psychiatrist, the behavioral health care manager, you can actually do something about it and prevent people from killing themselves. Depression is roughly about 0.1% lethal disease. So it is something to make a big deal about at this point in time. Next slide, please. So some of the numbers with our kids. This program has only been really operational for about a year and a quarter. And as you see, our numbers before we did the modules were pretty minuscule, pretty small. Looking at going back to the coding and doing claims analysis. But what we've seen in the year that we've really kind of started this, it's really jumped up twice what it was in the year prior, and is really following a very almost logarithmic, it's more than geometric here, kind of halfway between the two, increase. And we're also continuing to increase the number of pediatric practices. We just had a training in August, and I believe in that training we had 20 pediatric practices. We had another 15 or 20 general co-care practices, and we had our OB-GYN. We had 4 different physicians that came to that represented 3 practices, and our substance use disorder module was trained up for 2 practices. So it really is starting to take fire. This is really important stuff to be doing. And the last slide, you can move to that. the key takeaways. You all know these things. I think I'd rather open it up to questions. We have about 10 minutes to be able to do that. And whatever is on your thoughts, just go ahead and fire away with them.
Great, thank you very much, Bill. Okay, questions? Again, you have the chat room. But while we're waiting, Bill, a question, a clarification on I thought you said 5,000 plus patients have been through collaborative care. Was that number inclusive of children, adolescents, and adults? And if so, what percentage of it is now children and adolescents?
Yeah, the by far and away, it's adults, and that also includes people with Medicare, or Medicare as well. So we're looking at older adults. Older adults really like this as a way of being able to get their needs met. They tend to shy away from seeking out psychiatric or behavioral health care just in general. And this way they actually get indoctrinated into it and really like the way it's able to resolve some of their issues. But probably looking at percentages, we're looking at less than 5% are kids at this point.
Sure.
As you know, there's turnover, so that 5,000 represents all the people that have gone through in the 4 years.
Yeah.
It has continued to escalate, but it is something that you don't start out from the first time you open up a door and have people wander in. It takes a while to build up these numbers, and then they tell others. The thing is, that's where you start getting the word of mouth. That my doctor does this in that practice. Why don't you come over to his practice or her practice? That kind of stuff happens, and then that gets other doctors thinking about it. I think the biggest thing with doctors is the issue of burnout, and I'll speak to that real quickly while waiting for any questions. Is that the primary care doctors, initially it takes them a lot of energy to be able to get this up and running. It's a huge transformation. But I keep on running into primary care docs that say, I'm glad I did this. I like my work again. I was thinking of retiring, and now I want to continue practicing. Same thing for psychiatry. When they pick up 10 hours of their week to do the consultations, they get a variety. They have to think again like doctors. They have to think about the medical aspects, the medical acuities, the interactions with the medical medications, all of those things. And many times they come back and say, I really like this part of my practice. I'm going to increase the number of consultative hours I do, those kinds of things. So it really helps that burnout, and we can't afford the burnout. In Michigan, it costs about $2 million for us to bring a graduate from an undergrad program through medical school and residency in practice. So as a society, we can't afford to lose those people. There's a question. Linda.
Yes, Bill, Linda Raines with the Mental Health Association of Maryland, co-partner with John Miller on this Mid-Atlantic Path Forward group. Fabulous presentation, was really inspiring, I think, to hear firsthand what you've been able to do in Michigan, especially as our state is embarking on moving forward with this. And I know you said the data is coming early in the new year around your outcomes and the ROI on changing practice in this way, but I just wonder if there's any anecdotal information you can share in terms of what you are seeing about cost savings or those broader benefits of the program beyond serving patients better, which of course is our number one goal.
Yeah, I have some on a group that picked up wanting to do this work for people with chronic mental illness. And so they take care of people with schizophrenia, bipolar illness, recurrent major depression, personality disorders, et cetera. And these are stable patients, but as you know, people with schizophrenia die 28 years earlier than age-matched populations. So they've been able to get significant improvement of decreasing hospitalizations, be it medical and or psychiatric hospitalizations. And this group, I just got a presentation from them yesterday, so I'm doing this off the top of my head. 57 patients this year. All of them had significant psychiatric and medical hospitalization histories. One of them had a 25-pound weight loss, taking care of their diabetes with an A1C that drifted below 7. They had been running 9s, and in the BMI rate of about 28. Prior to this, now they're in about a 20 I think they did 26 BMI with that particular individual. Seeing that consistently across the patterns with these folks. They're getting their long-acting injectables in this practice, so they stay on their medications, so they don't end up having the ER visits, the psychiatric hospitalizations and rehospitalizations. The dollar amount, we didn't do dollar amount. We looked at just those kind of broad parameters. And again, the dollar amount will come in our more thorough evaluation of our claims. But we've had some significant cases with people with schizophrenia, just on another kind of view of it, that have been total medical spend in the $120,000 range. And once they get their behavioral health condition under control with a really strong case management program we have, that usually has drifted down to half of that. So we're anticipating the same kind of things in collaborative care, that once you take care of the underlying behavioral health condition of a diabetic, say, they can focus on their needs, they can focus on getting proteinaceous food, they can focus on getting back to work, all of those things that can get them back into society and quality of life better. And we've seen so many anecdotal things of quality of life improvement. It's been pretty substantial.
Thanks, Bill. That's really hopeful information, especially since we're all trying to spread the health and mental health dollar more widely, because especially in the behavioral health area, need is up so high. So being able to do it more efficiently so that more people can get served is couldn't be more important than it is right now.
Great, thank you. Other
Well,
questions?
another way of looking at this too is that I can make a real quick statement here and then I'll answer another question. I talked with folks from Mayo Clinic. I've talked with folks that have been doing the psychiatric consultation work. My practice, I could panelize at about 600 patients that I could see because I had a busy inpatient practice and general medical hospital practice. But most psychiatrists panelize at about 1,000 patients at the most that they can handle at any one point in time. Talking with people that have been doing this for a while, once you get the swing of it with your behavioral health care manager and your primary care doctor and you're working really well, I believe you can have the influence on 2,500 patients for that psychiatric influence in this kind of model. So you're more than doubling the efficacy of the psychiatric resource that we have in the country in this model in doing that. It's not direct treatment, but it's influenced care that is better than the way it is now. So there was another question.
I have one. I was waiting to see if others have any others, but let me ask this one while we come up to the hour. You talked a little bit about a 50% drop-off rate due to the copay. And as we wait for the preventive task force to sort of, formally classify this, how have you addressed it along the way within the Blues, the copay issue? Because it's an issue that comes up all the time with practices I've spoken with.
Well, we did a lot of work, and our fully indemnified plans, we can do that as a benefit change internally. We then talked with our customers, which we have a lot of them. Many of them were asking us to actually do that, which I thought was a bit odd, but when you've got big customers that are asking you to do things that are in the member's best interest, it's like, hey, this is really good. So we were able to do that. There are certain plans with high deductible plans that you're going to run into trouble with, and you can't really do that completely. But the ones that we can manipulate like that, we did. And that's been a really substantial part of our book of business, as to be able to do that. And with that, we have not seen anywhere near that dropout rate. It's probably around closer to 10%. And many of it's because they lose the insurance, or they're in our independent business unit, which is the healthcare.gov silver plan patients. They lose their insurance because they don't pay their premiums, that sort of thing. They drop out. But most people that get into this, they stay until they're really stable and that they're discharged by the primary care doctor back into the regular routine management protocol.
Wow, thank you so much. And, for those of us who've been watching your work over the past few years, we look forward to it continuing. Would love to see the data as they emerge from what you're doing, particularly with the kids, children, adolescents. So thank you so much, Dr. Beecroft. And again, Claire Gregory, thank you, as well as Nancy and others on your team for taking time today. Let us know about the Maryland rollout. So any final comments, Linda or John, before we sign off?
Yes, I have a final comment, Michael, and that is I'm picking up on your observations of the copay challenges you're facing, Dr. Beecroft, and all I can say is shame on us as employers if we're so short-sighted that we can't see the ROI of this minor investment in the long-term return. I'm doing my best to change that in Maryland as fast as I can. So thank you very much for the presentation. I applaud you.
Thanks
Yep.
for having us,
Thank you.
everyone.
You're welcome.
Oh, sorry.
Yep. Thank you.
Any Claire, were you saying something?
Yeah, sorry. I was just saying thank you for having us. We really appreciate it.
Oh, not at all. Thank you. Okay, well, thanks everybody for taking the time. And as I mentioned earlier, we are considering extending this series. We haven't worked out the detail, but we have some interesting potential presentations. So we'll get back to you. You'll hear from us. Thank you all. Have a great weekend.